and it's really a delight to be with you all. And want to congratulate my colleagues, the dean, everybody at Texila, the executive board, Dr. Jagan, who has been so hardworking for this conference, and everybody behind the screen, and of course our hardworking students. So we're very proud of you. I want to also acknowledge the presence of my colleagues who are from the UK, who should be joining us for their own presentations. Thank them for that. And also to all the support staff and persons who may not have mentioned. So today I'm talking mostly about suicide, and also was asked to talk a little bit about physician burnout, but we had such a very good presentation from our student that it is not much for me to talk about that, but there are a few slides at the end of the suicide presentation which I'll share. So just to look at what we're going to cover in the next hour or 40 minutes, because I've been asked to keep it to 40 minutes in case there are questions. And so we're going to cover the problems that we see with this terrible tragedy, suicide, look at some of the causes and risk factors. And stats, of course, are important to know how extensive it is. It is very extensive, as Dr. Bansal said this morning, where WHO is talking about 800,000 suicide cases a year, one in every minute or less than a minute, you find a suicide somewhere in the world, and that's truly tragic. And then we'll talk about how can we help and prevent this tragedy. So in terms of what we know, the problems and the factors that would affect the suicide rates are quite a number. So when we're addressing the issue of suicide, we're not just talking about the problem that a person has in the emotion. We're also looking at the cultural issues and the political issues and economic issues. These are forces which can impact on the individual in a very negative manner. And we see this kind of forces operated in the countries where suicide rates are high. And within the last decade, the traditional suicide high rates are in the Eastern European countries. So there are a lot of problems there in terms of politics, in terms of pressures in society, economics. We see those factors manifesting as suicides. And as you would expect, the rates are lower in countries where there's stability in the economy, there's openness in their thinking, there's very vast acceptance of people's cultural acceptance is high. And those are countries like the Scandinavian countries, which are traditionally lower. So social changes with modernization also is a negative factor. And as we heard in some of our speakers, we're seeing some of those changes impact us now in the time of COVID, which is causing significant social change. So another very interesting opinion here is that suicide has a social and moral meaning, and in terms of how it is viewed can affect how it occurs. So in some societies, it's seen as a moral problem where there's significant stigma attached to suicide. So it's frowned upon, and as such, you may find it's not an acceptable option. Whereas in some societies, it seems to be the way that person turn to a release of or an escape from their difficulties. So we got to bear these factors in mind as we explore the problem of suicide. And I brought this slide because I lived in Grenada for some time, and we have a scene here which is truly tragic. This is a situation of mass suicides where the Carib Indians, in order to escape the French, took the route to commit mass suicide. So they preferred to leap to the fate of death rather than be ruled by the French, and the fears of the domination by this outside race was so enormous that they took the leap here. It's called the Carib leap. but if you go to Grenada and you look at this point, it would be pretty horrifying to see the distance that the persons would have fallen. And it meant that it was a willing choice because they were looking at persons who were jumping and then they were jumping behind them. So really horrific to see that human beings would choose this recourse and what would be in a person's mind as they actually took the leap. So it's called the Caribs Leap. Not sure if many of you have been to Grenada, but I lived there. It's a beautiful island. The Carib population is small because of the loss of lives. So you have a larger Carib population in countries like St. Vincent, Dominica, and of course we have our indigenous population in Guyana, the Amerindians. So the problem of suicide is not one country alone, it's worldwide, it covers the entire globe. But you know what is truly sad about our country here, Guyana, and I mean, tailored this presentation to Guyana because you students are here in Guyana and many people who are listening in are from here or have connections. And those who are visitors who may not know much about Guyana would be surprised to know that of the countries in the Americas, Guyana is the number one for suicide and currently still. And it's also very high among all the Caribbean countries. So what makes us in Guyana a unique country for suicide is worth many studies, and we've had a paucity of studies. So I see our students producing beautiful studies and research papers. Congratulate you for that. And you would also be working towards understanding what are the factors here in Guyana that's led to this very high rate of suicide as we move forward in your clinical training. So keep up your good work. We want our school to really lead and show that power of knowledge students are doing. So here we have the data, and this is 2011, where Guyana was number 2, Greenland, strangely, was number 1. So Korea was 3. These are European, so but we were number 4. So that wasn't something to be proud of. And even worse came in 2012 when we were found by the WHO to have the highest suicide rate globally. And you know, the countries of the Americas actually were ranked in the lower group. So the countries that are the higher group are the Eastern European countries, but the countries of the Americas, which Guyana falls in because we are South America and part of the Americas, we are actually the highest, whilst the Americas themselves are not the highest in terms of being ranked for suicide rates. Trinidad, in terms of the list of countries, which is our neighbor next door, has a ranking of 45 at that time. And that's interesting because, you know, this Trinidadian demographics are similar to Guyana with a fair amount of division between our Afro-Guyanese population, our Indo-Guyanese population almost being equal. And that's quite an interesting demographic fact. So it tells us it's not just the ethnic breakdown of the population, there must be other factors. And that factors are pretty obvious when you think and reflect on our history of abuse politically, economic deprivation, and we're still now struggling out of that. And we're fortunate, of course, to have oil in our economic resource bag, but it's a concern because, you know, we got to be careful about how you manage modernization. That can also impact on social development. But a country like Dominica, which is a Caribbean country, is not even in the list of countries for suicide rates. So most Caribbean islands are actually very low for suicide rates, like Antigua and so on. They're very low. This is the most recent data from the WHO showing in 2016, the breakdown, as you can see here, the European, this is the Eastern European countries are very high. They're very high. Where the Americas are here, we are in the Americas, we are at number one in terms of the Americas. So it's not a very good fact. It's still there for us. Now in 2016, this slide is not very clear, but if you can study this a little bit intently, you'll see we're at number three, and Guyana is here, Lithuania is up there, then you get Slovakia and so on. So the Eastern European is still high. Eastern European is this block here, right? And we're stuck in the Eastern European block. It doesn't make sense, right? So as we're going on, I'm sure there are questions in your mind that you'll be saving up for either at the end of my lecture or to the panel discussion. So let's look at some of the facts of what we know. And there are not many studies, well, we do have some that in actual fact, we see more suicides by males, and that's a worldwide factor. So we find that worldwide, the demographics are usually older males who would commit suicide. But in Guyana, actually, it's the younger males who would commit suicide more often. And more often, it's the East Indian population that is vulnerable. And there are also suicide belts in Guyana where you find in the Berbice region, the Blackbush Polder, and parts of Essequibo. In those regions, you find high suicide rates. So what are the factors? I have a theory in terms of that, in terms of maybe a possible gene factor. So it's something that we may want to look at and study. We know also the methods here are lethal. For example, the use of bromoxone, which is a insecticide, a pesticide. It's pretty lethal, and it's a truly sad way to die because persons may have resolved the conflict after they do an impulsive act of taking the pesticide, but there's no reversing the damage that bromoxone or paraquat causes because it eventually leads to pulmonary fibrosis and death, a very, very, very painful and horrific death. So very few people I've only known 1 or 2 cases of survival of persons from paraquat poisoning, and usually it's because they were able to throw it out. They actually took it by mistake. There was one man who was drunk and he got home and he reached for his bottle of rum and took the bottle of insecticide by mistake, but he was able to throw it out and he survived with tremendous lesions and adhesions in his esophagus afterwards. So he had to walk around with, he had to have a laryngectomy done to help open his airways. So these are the stats for Guyana. We see that high in this age group, the younger age group, most by pesticide poisoning, and hanging also, as you know, is also very common. So in what happened, I've seen in terms of the pattern, that as the pesticide use is less, the hangings are getting more. And it's also of young people as young as 12 and 13 who are hanging themselves in the rafters of their home. So the second leading cause of death among our females, and the leading cause of death among our young females, second leading cause of death among our young males. So these are the regions, as I mentioned before, quite a number of cases from these particular regions, the 3, 4, 6 regions, region 5 also there. So why in that particular area are we seeing this pattern of behavior? Of course, there's the influence of behavior that impacts others. So some of the background theories as we move forward, depression obviously is a very big risk factor. And in these days we have depression secondary to the COVID crisis. The lockdown is causing some very negative feelings on people. The social life has changed. Children are at home. They're not socializing anymore. There's a lot of fear. I think the fear factor is certainly very dominant during this COVID crisis. The fear of people dying, was persons may not even be in a group or category of people who are high for fatalities. As you know, the COVID is more the older persons, especially persons who are obese. While that's not the case, even persons who are younger experience significant stress. Then the lockdown itself is a problem. And you can see here the Germans fighting against a lockdown that was ordered. And it's not nice to see that going on in our world today, where they were even sprayed with pepper spray. Uh, Look at that, at the people by the police. So the kids are feeling very disturbed. We had a story in Baltimore, which I found where a kid turned to suicide. And here the parents are obviously in a lot of pain, and they're saying that the kids to be home by themselves all day long, no consideration, no plan, it's got to stop, and something for educators to think about, and even our students, you're pretty wonderful to be able to be coping and to be attending, doing all your online work. We must commend you in that, because kids are very depressed as a result of being locked away. It's not part of their natural process of growing up, but they want to be social. They want to be able to meet and enjoy reactions, interactions. So here we have this situation where the parents were complaining to the school, and the school just brushed it off and said, no, he will be fine. And stay the course, he will be fine. And the kid went on to, that's a little boy, he was 14 years old when he committed suicide, grieving parents, with Baltimore in the US. Other big factors, and this is one of the big ones in Guyana, of course, that alcohol is widely used, even among the young people, and it's a big concern. We're not seeing it enough, but we got to see more efforts made to stop that, and that's one of the problems. Depressed, the serotonin levels go down, and the amygdala becomes dysregulated. They start to get bad sleep, they get nightmares, bad dreams. And then, of course, as I mentioned before, the genetic basis is also very high. So, as a factor, family history, if you take a history of a patient with depression, don't forget to ask about suicide, because many a times a person's entertaining thoughts of suicide is a family history of suicide, and it's a very high risk factor for that individual going on to committing suicide, family history of suicide. So we have other theories which are very common, and maybe also very common among young people, where the love relationships in our young people is very, very early on, and almost culturally acceptable that young people would start to be paired up, and they're almost like in a match for life. And as we know, many of these relationships don't go on. So the early relationships tend to break down, and the persons can't cope with that kind of loss. So the key word here is, of course, loss, or a reaction to significant illness. So we had also a psychological theory where people who start to feel very depressed about the loss could internalize that loss and end their life, sort of taking themselves with the loss that they experience. So easing the pain. And this one here is the rage theory, where the person would act out impulsively in severe anger, often killing the person that they previously loved, and then going on to end their life. And that's the manager theory to suicide. Some interesting social fact, we do see the domino or the contagion effect. And these are very countries would carry high domino effects where they would have people commit suicide when they observe suicide in other folks. So it's something to bear in mind because we often see a pattern of suicides happening one after the other, where a person here, I think this was sometime in December 2014, this lady jumped off the Demerara Bridge, and then subsequently another woman jumped off the bridge in January. So just within a month, so would she have had the news of that first death, and then she here, that's a lady here walking, and she's going on to go to jump the bridge. So truly tragic. So that's a little bit about the factors that we see for suicide, some of the demographic, some of the social issues. Let's talk a little bit about strategies for preventing suicides. And there is a national health strategy for suicide prevention. So there's a program in place. It's how it's now implemented, that's the question. So while there may be programs and there may be kind of measures that are developed, we do have good measures. A suicide hotline is there that was recently opened too. So there is definitely a will. Our ministry currently with our minister who came today, and one must commend him for the amount of work he's doing, making changes in terms of protection for us for the COVID. Now we see work in the mental health legislation, which he mentioned, which is really outdated. And so we're looking forward to support that we can make a difference. There are some studies that talked about suicide rates in Guyana. Dr. Beckles, who passed on, but he did a study with the Dutch from Maastricht University. So Dr. Ramsamy, who was a former Minister of Health, he in 2010 established the Gatekeepers Program, which is shown to be very effective and powerful as a mechanism. I was talking to Dr. Caetano Claudino, who is Director for Mental Health with PAHO in Washington, and she talked about how in Belize, where she's from, how they actually have a program of an alert system where anybody who is suicidal could connect to that system, and then the alerts go to all the various agencies. So a lot of effort now, not only because the family will be trying to save and help the person who has attempted suicide, but a lot of support from counselors, medical teams, and so on that would help. Another good thing in Guyana is they're making more efforts to control pesticides. So we are looking forward to seeing that the suicide rate drop. The moment it's still high, so the question is, why are we still seeing such a high suicide rate? So could it be economy? Could it be cultural? There are groups, of course, that are very active. This one is an advocate for us, the Caribbean Voice, Mr. Anand Budram, who is behind this. He's a powerful force. He's been writing for a long time in the newspapers, and this one is published in 2014 and focusing on suicide prevention. That's one of the big issues. I think that's one of the foundation issues that that he launched his Caribbean Voice, is the group that's helping. And it's Facebook, so he has me on the board of directors. I must give him, of course, very, very positive kudos for his work, because I'm able to see what they do. It's a really good Facebook page. So students, doctors, do look at what is posted there. Let's be all part of this battle to save our young people, save the lives of our people, our kids. We can't lose them to suicide. So a little bit in terms of protocols, for those of you, and all of you should be interested in public health issues. A good physician is not only a good clinician, diagnostic person, but also able to do good public education and patient education. So the three ways we do suicide management is to look at the risk factors, the protective factors, and the warning signs. So we get information from about these three things. So gather information. For example, if I had to ask you now, what do you think are the big risk factors in Guyana? Well, we already covered some of those. We are looking at ethnicity, we're looking at region, we're looking at genetics, we're looking at alcohol, we're looking at age. So we got five, but maybe you may be telling me some more. All right, we look at finances, we may look at cultural views, we're looking at relationships. So they're quite a number, you know. It's the social, political, economic factors or forces, as we call them. To collect information related to the suicidal behavior, I know Dr. Ramsamy, who is now an advisor to the government, is looking to do some research in this area, but maybe our students can help support that. We want to know what's in the mind, how do we track people who have attempted suicide and recovered and are safe now? What was it that led them to that kind of behavior? So clinical formulation of risk based on the databases. We want to study protective factors. We want to enhance these factors. And they are there in all societies. Cultural, protective, religious beliefs is very strong. People have religion, they have more support. We know that fear of outcomes. Some people don't know what's going to happen to them if they ended their lives. Future goals, once it's clear, they tend to have a purpose in life. Family connections are very important. That's also a very bad factor for Guyana because families were sort of destroyed by political activities in this country and a lot of migration of families outward. So truly sad. Impulse control problems and emotional regulation are emotional problems. So a nice slide here to show protective factors in terms of societal, community, relationship factors interacting to prevent these factors from acting on the individual. So problems like mental problems, if we address these, we're gonna reduce suicide. If we able to reduce violence and violent conflict by anger management. I had the pleasure of meeting Mr. Jerry Gavaya, who is now the National Security Advisor in the government, and he's looking at programs and ways to manage people who have anger issues, and that's important. So it's not one solution, you see, so it's got to be a multiple support system solutions that can help stop this epidemic. So personal tragedy here. This is a story here written by Jameson. It's private. It leaves families, colleagues, friends with a loss, guilt. It's an aftermath of confusion, devastation. It's terrible. Truly, truly devastation on the family. Just for, to be complete, we do have some screening tools that we can apply, could actually screen people for suicidal thinking. Another thing that some of you students may want to do to try to research what might be ways to recognize people who may have suicidal problems. So the collective approach is the way forward. We got to work with our leaders at all levels, especially from the community level. So that's a step ladder approach. And as you can see, define the problem in the beginning, identify the causes, test intervention, implement those interventions, and then evaluate. Evaluation is critical. I've found that if we are not going to be evaluating something, it's not going to be understood in terms of effectiveness. We might feel we're on top of it, we're doing the best job, we can have the best plans in place, but unless you evaluate your success, then we don't know. And that's what we think we're lacking. So we got to be able to have a good surveillance system in place, be able to evaluate and protect. So we should have a national plan that is active. We do have a plan, but how active it is the question. But the plan should, of course, be culturally sensitive and sustainable, manageable, and for everybody. I just want to, on this topic of suicide, mention this issue of journalism because we do know the worders domino effect is there, and how people portrayed suicide in the press can be also very negative, can lead to other people acting out their feelings because they feel somebody has done it, I can do it too. We don't know that intervention works, so here we have somebody who is writing about Jameson again, talking about the debt that it's owed to the doctor, the psychiatrist who helped him. So never condescending. We got to be very careful how we communicate to our patients, not condescending, saying rude things to our patients, minimizing their fears and concerns, but causing them to feel worse about their situation. So that closes that part of my presentation, and I think I have about another 5 or 10 minutes, so I'll go on to talk a little bit about burnout in terms of falling onto our very good presentation from our class student, the class paper, the excellent paper. And this is more in terms of evaluation recommendations. So just want to quickly start with a case, and here we have a medical resident falling asleep and not able to answer a medical call, so was reprimanded. But he had been working for over 18 hours, so that's clearly beyond the human capacity. So that's too bad. We shouldn't be scolding him. We should be supporting him. So what happened with him? He was actually having, so these are some questions I want you to look at. So what do you think was causing his deep sleep? He couldn't answer the call, you know? And let's say he even answered the call, how effective would this doctor be, you know? And then if he committed a medical error, we're going to be on his case even worse than the scolding he got. He may now have committed something that would have led to somebody's death. So sleep deprivation would have been the factor that led to his being so deep in sleep. And if he had woken up, he would have obviously been very confused. And so could the hospital be liable? Yes. So something for us to think about, culpability when persons work so long. And of course, now there are many places. So it wasn't easy to make those changes. Doctors had to fight for those changes. So we know that 7 hours are minimum. Some people tell me they do 6 and they're fine, but usually the studies are showing that 6 hours are not good. So you're talking about 7 to 9 hours, because less than that, there could be accidents, problems with driving. And these are the occupations that people get sleep deprived a lot, shift workers, obviously, physicians, nurses. So sleep is very, very critical to function. Something that we take very natural, like eating food, you know, but sleep is very critical to being able to function and focus well. And if we're deprived of sleep, then there's a lot of tiredness in the day. People can just fall asleep at the wheel. There could be accidents driving. There's obviously poor concentration, memory problems, irritability in the mood. You know, so when we see somebody who's irritable, maybe we could ask them, by the way, did you have a good sleep? Were you able to rest the day before, last night? Agitation. So here, think about this. Think about this. So we got a system not only the health system is very exacting. I found situations that are amazing, that, you know, a doctor could be saving lives every day, but that one time when that doesn't happen, the system jumps on him and says, well, you messed up, you know. And so there's a lot of pressure, not only by the system, the doctor himself has this very high expectation. Doctors don't like to make mistakes. You have to say a wrong word, they'll tend to get very upset, and they carry it in their mind. So there's a lot of pressure on our physicians. But here is a situation in Guyana where we have so much congestion on the road, it's very hard. You got to have doctors sometimes coming in from different places, driving for over an hour and a half, and through traffic and irate people on the road, and buses that are weaving and cutting into, I don't know how many buses have driven on the East Bank in the rush hour, but it's horrific. It's like getting out of Georgetown at about 4 or 5 is at rush hour is like a nightmare. So and then they got to be able to function well. So could the country itself be liable if a physician wasn't able to perform well? Because the origin of the tiredness that the doctor has is traced to having to get up so early and have to go through a lot of traffic and stress. Okay, something to think about, just a reflection point. Maybe Dr. Ragu can relate to that because London has a big traffic problem. I know I made a mistake once of driving through London, and I never drive again through London. I take my chance in Georgetown. So let's look at the PET scan, positron emission tomography scan of exhaustion, and you can clearly see that physical change that happens in the brain. So this is not about somebody saying that you burnt out. You are burnt out. It's there. There's physical evidence for it. You can take this to the court and show them, look, this is my brain. So things that we do can make things worse. Drinking, of course, using a lot of coffee. Marijuana is not a good drug to help manage stress. Maybe to go and meditate, who wants to do that? But to go and drive, it's cause vicious spatial problems. It's not going to help. People sometimes are totally stressed out in themselves. The personality is added to it. So the American Medical Association defines what impairment is amongst our doctors. So we got to be careful, you know. We also should have medicals. You know, doctors don't go and get medicals. It's like they're impervious to the belief that they don't have health problems. Many a doctor, including myself, don't do enough to care ourselves. So we got to be conscious about our own health, because we got to be able to support ourselves, our colleagues. Many a time doctors believe that if they were to report difficulties they experience, emotional bad feelings, even suicidal or depressed feelings, they would be looked down on. People would not want to see them as a doctor. So we got this mentality that contributes to problems. But doctors are truly a very valuable resource. They're trained for a long time. A lot of money is spent helping to build that doctor in his career. So we don't want him to lose his career. Of course, physical examinations will rule out problems like anemias and other psychological disorders, autoimmune disorders. So the annual physical should be mandatory for doctors. That's for me, including for me. So we make the vaccines a very important drive. But, you know, as a side, to something, it's truly sad. But if you actually study number one deaths anywhere, especially in America, 7 times more than COVID is cardiovascular disease deaths. But yet we don't do enough to talk about lifestyle change and changes of behaviors that contribute to heart problems. So that's what happens as the person deteriorates, the changes, eventually it impacts on work. So work is the end result. So we gotta be very careful that this doesn't happen, that people can show these behaviors. Now that's the thing, if we see these behaviors, let's try and they're becoming sort of promiscuous to us, very, very bad behavior. Let's try to find out what's behind that so that we can prevent medical errors. Here is a case where chlorpropamide was given instead of chlorpromazine. They're both very similar. And obviously, this one is going to cause severe hypoglycemia, and the patient was brain dead because of being made into a hypoglycemic brain coma. 1 in 2 physicians in the US, and there's a study from the Mayo Clinic showing that 1 in 2 have burnout. And if you look at the reasons people are getting burnout, it's getting more because of the COVID crisis. We got the crisis now on top of us, the fear of exposure. Studies are showing that health workers in some places are actually suffering more in terms of infection rates. So there's a lot of pressures, moral dilemmas in terms of the COVID crisis being stigmatized. So here we look about generally among professionals who tend to suffer more among professions, and our doctors and nurses are ranked number 4. So we know people who are in nursing homes, they also suffer quite a lot. And that's a very sad fact that we can lose 400 physicians. Some of the big schools like the one I came from would have a class of about 400 students. So we're going to lose a class, an entire class, an entire semester because of suicide. So we find in the females, very interestingly, that female doctors tend to have a higher suicide rate. Look here, female physicians than the male physicians. So our lady doctors are under tremendous pressure because there's so many expectations of our lady doctors, from home to work, for themselves, for progress. So that's burnout rate by specialties. We find emergency medicine is very high. There's a lot of pressure there, internal medicine. So some of the lowest pressure specialties, neurosurgery, psychiatry, and the lowest being dermatology. So high ones up here, orthopedic surgery, family medicine, neurology, emergency medicine, very hard. So why do doctors seek help? Because many a time they feel, this one here is that people will see them negatively. And is that true? Yes. Unfortunately, sometimes we in the administration would view that doctor negatively. Sometimes they feel they become the butt of jokes, that people now laugh at them and say, this guy cracked up, he can't handle the stress anymore. So stigma is very strong against doctors who talk about themselves, about the emotional stresses. So to prevent this, we must have policies in place. We must encourage doctors, as our student said, have a good wellness. Many of the hospitals I know here that have wellness programs to the staff, as far as I know, very few. We just started somewhat of a wellness program at the St. Joseph Mercy Hospital with the social group formation. So that in a way, that's a wellness group where people would share jokes and talk about lighter things than just talking about work and patients. So we must have a program and administration that sets up these policies, support groups, sports, that's very powerful, regular physicals, drug screens, employee assistance programs. All these are very powerful programs to prevent physician burnout. And with students, you also need to have some of that. You have it somewhat with the groups and support groups and time out and learning more about the other side to medicine, you know, the invisible side, which is our emotional side. Debriefing, how many times do we debrief a physician who's lost a patient? Not at all, you know. You have mortality conferences sometimes in some places. Very few places offer debriefing for the staff. Not only doctors, we're talking about nursing staff. The nurses also experience tremendous amount of stress because they feel the doctors may blame them, which may often be the case. So we got to debrief to make people understand what happened and without blaming each other. It's absolutely a tragedy when you add tragedy of behaviors that are not right on top of a loss. So in Guyana, of course, we have to try to get better ways to get our doctors supported. I actually wrote asking for consideration for our doctors who drive and so they can have proper parking so they can get to work supported because some of the police, they sort of really one track in their mind that you're not supposed to park there. They don't care if somebody's lying in front of them with a heart attack. It's like, no, you can't park there. You gotta go move your car, deal with a heart attack later. It's like unbelievable. So there are some practical things that we must have our administration or ministries or permanent secretaries, anybody in power or police give us that support. So I want to thank you very much for having me. I know it's quite a lot of information that was shared in a very short time. And I was really glad to be with you. And if there are any questions for me,